You can exercise daily and eat healthy and get a clean bill of health from your doctor and still be at a high risk for a heart attack. Because the standard checkup that most people get every year often doesn't catch problems until they're far along, and it doesn't look at the right markers to begin with. So you can have normal cholesterol and feel great and get told everything looks fine while plaque is quietly building in your arteries. So in this video, I want to show you what actually drives heart attacks in seemingly healthy people. And we'll talk about the hidden risk factors that routine screenings miss. And we'll talk about specific tests that you need to ask your doctor for before it's too late. And if you're new here, I'm Dr. Kim. I'm a double board certified physician, and on this channel, I break down the most up-to-date and evidence-based information on longevity and metabolic health and weight loss. And as always, even though I'm a physician, I'm not your physician. So please talk to your doctor before making any changes to your health regimen, as this video is educational only and not medical advice. So let's start with something that I think most people, and honestly even many doctors, underestimate, and that is inflammation. Because here's what the latest research is now making abundantly clear. You can have perfectly controlled cholesterol and still be at a significant risk for a heart attack. If inflammation is not addressed, cholesterol management alone is not enough. And the study that really drove this home for me was the CANTOS trial. So in this trial, researchers enrolled over 10,000 patients who already had heart disease. But here's the key detail. Their LDL was already reasonably well managed, with a median LDL of just 82 milligrams per deciliter. Which, by the way, I'm going to tell you later in this video how I approach LDL targets with my patients. But in this study, for the most part, cholesterol didn't seem to be a big problem for these participants, but their inflammation was still elevated. And the participants' inflammation was measured by checking a test called high-sensitivity CRP. So the question those researchers asked was simple. What happens if we lower inflammation without changing cholesterol at all? So they gave one group a drug that blocks a specific inflammatory pathway with zero effects on cholesterol. And just by lowering inflammation, major cardiovascular events dropped by 15%. And the patients who got their high sensitivity CRP all the way down below 2 saw even a bigger, a 25% reduction in major events. And they saw a 31% reduction in death from any cause. And this was seen in larger studies as well. So there's a more recent collaborative analysis that looked at over 31,000 patients who were already taking statins. And even in people whose LDL was treated, those with high sensitivity CRP above 2 still had double the risk of cardiovascular death compared to people with low inflammation. Now, just to be clear, this does not mean we ignore LDL. LDL is still a causative factor in plaque buildup. And I'm actually going to show you a better way to measure cholesterol risk in a moment, but this data tells us something important. Cholesterol and inflammation are separate problems, and you have to address both. And as a matter of fact, the American College of Cardiology actually put out a scientific statement making exactly that point. High sensitivity CRP, which is a marker for inflammation, predicts cardiovascular risk as well as, and in some cases even better than, your standard cholesterol numbers. And this is one of the major reasons why people who look healthy and have normal cholesterol numbers still get heart attacks and strokes. Their inflammation is just not under control. So here's how I approach this with my patients. We always check and trend high sensitivity CRP. And if it's elevated, we always look for the root cause of inflammation. Sometimes it's excess visceral fat. And sometimes it's insulin resistance, or poor sleep, or chronic stress, or even untreated dental issues. But the good news is most of these are very fixable. And when you fix the underlying problem, inflammation comes down and your risk drops dramatically. Now let's come back to the LDL issue and what your LDL target should actually be. And this brings me to even a bigger issue with cholesterol testing. Most standard panels check your LDL-C, and it's a decent marker, but it doesn't tell you the full story. This is why you can have a quote-unquote normal LDL, but still be at a high risk for heart disease. So in addition to LDL, I always encourage people to also check their ApoB, or Apolipoprotein-B number, which will give you a more accurate assessment of the risk. And here's why this is so important. So LDL, which stands for low density lipoprotein, is just one type of lipoprotein that carries cholesterol from the liver to the tissues. And it's often called bad cholesterol because high LDL drives plaque formation. But there's even more players in the mix that also increase your risk. So there's VLDL, or very low density lipoprotein, and IDL, which is intermediate density lipoprotein. And these particles also contribute to plaque buildup. So that means you can have normal LDL but still be at risk. And this is why ApoB is a much better predictor of heart disease. Each of those cholesterol-carrying particles, whether it's LDL or IDL or VLDL, they all have one ApoB molecule attached to them. So when you measure ApoB, you're actually counting every atherogenic particle, and you're able to capture the entirety of the risk. Now, for most people, ApoB and LDL, they move together. So if your LDL is high, your ApoB is probably high as well. And on the flip side, low LDL usually means low ApoB, but that's not always the case. And this is where people can get into trouble. Where these two numbers diverge and you get a discrepancy is when you have insulin resistance. So that would include things like prediabetes and type 2 diabetes and fatty liver or PCOS or even high blood pressure. And this is a problem because insulin resistance is becoming very, very common. It's actually estimated that up to 40% of US population without diabetes have insulin resistance. So if you have insulin resistance, it becomes that much more important to keep track of not just LDL, but the other lipoproteins like IDL and VLDL, or you can just check your ApoB. And once you measure ApoB, well, this brings us to another reason why seemingly healthy people on paper get heart attacks. And it comes down to the ApoB target you're aiming for. Most people think about risk in short windows. And that's because most physicians are trained to focus on just the next 10 years for risk assessment. And guidelines recommend using something called the ASCVD risk calculator, which estimates your risk of having a heart attack or a stroke over the next 10 years. And if that number comes back as low risk, well, the message is usually everything's fine, just come back next year. But here's the problem with this approach. Atherosclerosis, or plaque formation, doesn't develop in 10 years. It's a process that starts as early as adolescence, and we can actually see early plaque formation even in teenagers and young adults. And then it quietly accumulates over decades until it finally causes a heart attack, typically in someone's 60s or 70. And by the time that 10-year risk calculator flashes a warning, well, the plaque has already been forming for 30 to 40 years. And at that point, it's much more difficult to reverse. So the approach I use with my patients is a little different. Instead of thinking about the next 10 years, we're actually thinking about the next 30 to 40 years. And for that kind of time frame, the goal is to lower your ApoB down to below the 5th percentile of the population, which is roughly below 60 milligrams per deciliter. And if you don't know your ApoB and we have to rely on LDL, I recommend trying to get your LDL to below 60 or 70, as we have studies that show that that's the threshold at which plaque starts to develop. Now, that may sound aggressive compared to what your PCP may recommend, but when you think in decades, not years, the math changes. I think of it like driving in full speed toward a cliff and only hitting the brakes when you're right at the edge. By then, you run out of the road and it's very hard to stop before you fall off and have a heart attack. And that's what happens when you rely on a 10-year risk calculator. Only alerts you when you're already near the danger zone, even though plaque has already been building quietly for decades. But ApoB isn't the only hidden risk factor. There's a genetic marker that about 1 in 5 people carry that can double or even triple your risk of a heart attack. And it doesn't show up on the standard cholesterol panel at all. That marker is called lipoprotein-A, or Lp(a) for short. And I've talked about this in my other videos, but I bring it up because it's so important. Elevated Lp(a) is probably one of the most common reasons you see healthy people in their 40s have heart attacks or strokes with no warning. What makes elevated Lp(a) so dangerous is it's almost entirely genetic. You can't meaningfully lower it with diet and exercise. And most people have no idea they have it until something serious happens. So here's why it causes so many problems. Lp(a) is structurally similar to LDL, but it has an extra protein wrapped around it, and that makes it far more dangerous. And that's because this structure accelerates plaque formation, and it makes it more likely for those plaques to rupture and form a clot. And on top of that, Lp(a) can drive calcium buildup on the aortic valve over time, which can lead to a heart condition called aortic stenosis. So this is a condition where calcium is piling up on your aortic valve, which is the main valve that lets your blood leave your heart. And over the years, this can make the aortic valve stiff and narrow, and when that happens, that can lead to heart failure and all kinds of heart flow issues. So because of this, the American Heart Association and several major guidelines now recommend that all adults get their Lp(a) checked at least once in their lifetime. So because it's genetic and stays relatively stable throughout your life, you only need to check it once, but you absolutely need to know that number. Now, if you check it and you find out that your Lp(a) is elevated, well, unfortunately, we don't have any FDA-approved medications for this yet. But there are several therapies that are currently in phase 3 trials. And the data for those looks very promising. And I'm pretty sure we're gonna have effective treatments for Lp(a) very soon. But in the meantime, our strategy is to aggressively lower your overall cardiovascular risk as much as possible. So we really dial in on things that we can change. And that means getting your ApoB down to as low as possible, and keeping your blood pressure controlled, and addressing insulin resistance. And we reduce inflammation. Now, the next hidden risk factor is probably the most common root cause I see driving both inflammation and cholesterol in people who otherwise look healthy on paper, and that is insulin resistance. And in simplest terms, insulin resistance happens when your body has trouble handling sugars in the blood. So it shows up as fatty liver and high blood pressure and prediabetes, and eventually that progresses to type 2 diabetes, and it shows up in things like PCOS or high triglycerides. And we already talked about how if you have insulin resistance, ApoB then becomes a much better predictor of heart disease than LDL. But insulin resistance on its own is also an independent risk factor for heart disease. And it may actually be a bigger driver of heart disease than cholesterol. So in the Quebec cardiovascular study, people with high insulin levels, which is what we see in insulin resistance, had more than 5 times the risk of heart disease. And that was a much bigger risk than having high LDL or high ApoB. And here's the important part. Even men who had normal cholesterol but high insulin levels still had a higher risk of developing heart problems. And this is what makes it so easy to miss. You can have significant insulin resistance, but your fasting blood sugar and your A1C look completely normal. And your doctor may look at those numbers and say, oh, everything's just fine. But what those tests don't show is how much more insulin your pancreas has to produce to keep those numbers in range. So if your blood sugar is only normal because your pancreas is working 3 times as hard as it should be, that's not health, that's compensation. And that compensation comes at a cost. So to catch insulin resistance early, ask your doctor to check a fasting insulin level alongside your fasting glucose and your A1C. If your insulin level is high while your glucose is still normal, well, your pancreas is already working overtime. But the good news is that insulin resistance is reversible, especially when you catch it that early. And when you fix it, almost every cardiovascular risk improves at the same time. Your ApoB comes down, and your triglycerides improve, and your blood pressure drops, and inflammation normalizes, all from fixing the same root problem. And I won't go into the full insulin resistance reversal protocol here, since I cover this in many of my other videos. But the big levers are simple. So we reduce visceral fat, and we emphasize both regular aerobic and resistance training. And we cut back on refined carbohydrates and ultra-processed foods. And for many of my patients, these steps alone produce dramatic improvements in just a few months. Now, there's one more critical piece of this puzzle that I didn't cover in this video, and that is imaging. Because all the tests I just mentioned, your ApoB and Lp(a) and fasting insulin and high-sensitivity CRP, well, these are all blood markers. They tell you how favorable or unfavorable your biology is for plaque formation. But these tests don't actually show you whether plaque has already started building. And for that, we need imaging. And we use a few different tools for this. So we use tests like coronary artery calcium scoring, or CAC, or coronary CT angiography, or a test called CIMT, or carotid intima media thickness ultrasound. And each one of these tests will tell you something different, and each one is useful in different clinical situations. And I'm working on a dedicated video that goes deep on exactly that, which imaging tests to get and how to use them. So if you haven't already, subscribe to the channel so you don't miss it. I hope this is helpful, stay healthy, and I'll see you in the next one.